So welcome everyone. My name is Lisa Kelly. I'm co-founder and president of Mental Health Awareness of Michiana and Happy Maternal Mental Health Week. So we're very glad to be having this event and glad that you're all here at the Maternal Mental Health Symposium, helping Michiana parents be well. I'd like to thank our partners for today, Beacon Community Impact and the St. Joseph County Health Department, and thank our sponsors, Anthem Blue Cross Blue Shield, the Shaw Center for Children and Families, MDWise, and Indiana Tech. And I also want to recognize our planning committee, Jennifer Carter, Patty Miller, Justina Chisholm-Fikes, Robin Vida, Kelly Brienne, and Takesha Jacobs. And also thank our organizations who are staffing resource tables today. We will have short breaks in between sessions. So I invite you to visit the resource tables where we have drinks and lunch in that ballroom. When it's lunchtime, feel free to go outside to the courtyard. They just said don't go where the red tape is. Our mission is to improve the lives of those living with mental illness or mental health concerns in Michiana through initiatives that eliminate stigma, build collaboration, and improve access to care. As a clinician working the past 20 years with pregnant and postpartum women, today's event is close to my heart. The topics we're covering today are important, but they're also difficult. So every day, women's and families' lives are disrupted and sometimes destroyed by the issues that we're discussing today. Our interventions matter, all of our interventions, and helping a parent today, there's generational impact. So it's part of the reason that I'm drawn to working with pregnant and postpartum women is that if you can help that generation, you actually can help subsequent generations. So this work has impact, and so, you know, even though there's tragedy, there's also hope. So what I do want to say is that some of us may have personal experiences or have family, friends, and clients who we're thinking about during the course of the day. And I just encourage you that if you need to take a break, it's okay. It's a beautiful day outside, and just feel free to take care of yourself. So we've included some interactive sessions today, and they could be logistically interesting, but we're going to try and encourage people to meet new people, and so we'll talk more about it, but I ask for your patience as we're doing that. So I'm delighted to welcome our first speaker, Dr. Camila Arnaudo, who will be speaking on substance use disorder in the perinatal period, its consequences and mitigated strategies. Camila Arnaudo is an addiction psychiatrist based in Bloomington for the past 14 years. She completed medical school at the University of Maryland School of Medicine in Baltimore. She then completed her residency in psychiatry at Harvard, along with psychiatry training program in Boston, Massachusetts. After relocating to Indiana and working as a psychiatrist for a few years, she returned to training and completed a fellowship in addiction psychiatry at Indiana University School of Medicine in Indianapolis. Her current work focuses on mental health and addiction illnesses in pregnant and postpartum people, with a particular focus on increasing equity and accessibility to quality care. She's currently the medical director of the Addictions Treatment Recovery Center at IU Health and a member of the Indiana Maternal Mortality Review Committee. She's also adjunct faculty at the Bloomington Regional Campus of IU School of Medicine, where she teaches first-year students about clinical aspects of medicine, especially how to interview patients, and three-year students in the basics of psychiatry. So please join me in welcoming Camila.
All right, thank you so much, Lisa, and the team for inviting me today. It's my first time in South Bend, and I'm really, really enjoying it. It's such a beautiful city. I've gotten to do a little run around Notre Dame already, so very impressive. It's not Purdue, so I can like it, which I really appreciate. Thank you for doing that. But yeah, so thank you so much for welcoming me to this presentation and for letting me open this day. We are going to have so many just remarkable talks dealing with maternal mental health, and probably my talk will, among others, will have some really difficult parts. We're going to be talking a bit about maternal mortality. You know, as a perinatal addiction psychiatrist, that's one of the one of the sad or difficult parts of my job, but it's also a big motivator. A big part of my why is my ability, if I am able to engage people and get them on the right path, to potentially save a life. So I think it's a very sort of motivating and at the same time difficult topic. So as Lisa said, if it becomes too much for you, feel free to step out, come back in later, and it won't offend me at all. Totally get that. I do move around a bit, so hopefully I don't make you guys busy. That's me, you already know that. We have some learning objectives, we'll get through all of them, hopefully. So what are addictive illnesses? First and foremost, let's make sure we're all on the same page with this. The NIDA definition for an addictive disorder is a compulsive brain disease that involves continued use of drugs despite negative consequences. And it causes persistent changes in the structure and function of the brain. These can be reversed, but they don't get reversed immediately. For many of you who work as clinicians, you're aware, of course, of the DSM-5 criteria for addictions that involves, again, a lot of things that basically boil down to continued use despite negative consequences. So this is the textbook definition, but what does it mean in real life? This is from our neighbors in Cincinnati. I always think it's in Pittsburgh, so I finally looked it up and was like, this is from Cincinnati. And I think this really tells us from the words of the participants in their program, what their journey really was, from a chaotic existence with lots of negativity, feeling untrusted, to a more organized life in recovery. So this would be the ideal, sort of an ideal progression. So the perinatal period, a lot of us think of it as a time of opportunity, which it is a time of opportunity. It motivates people. There's a lot of things that our patients are, not all of you may be clinicians, but the people you're taking care of, they are very motivated to try to take care of themselves, to protect their, baby in a way that they might not be motivated for themselves. And so a lot of people will say, this pregnancy is saving my life. At the same time, it is also quite a risky time in terms of maternal addictions, because it's not exactly always turns out the way people expect it to. Even in good outcomes where you have a baby and you get to parent that child, they can be quite disappointing as little initial human beings, right? They don't really do all the things you think they do. They don't look like those babies in the commercial. You probably visualized certain things about how it might be, and then they come and they're little and they're wrinkly and they cry quite a bit, and your hormones are crashing down and you have to go back to work, and you maybe were someone who faced trauma as a young person yourself, maybe you didn't have the best parenting. All this stuff gets reactivated for you in the postpartum period, and sometimes even before that. So in fact, even though it's a period of opportunity, it's also quite a risky time for people with addictions. So substance use disorder in women, and I'll just say a word about language right up front. A lot of the studies and literature that I talk about were done at a time when we didn't really acknowledge the fact that not everyone who gives birth identifies as a woman. So sometimes I will use the term birthing people to be more inclusive, but some of the slides are based on data where they really were looking at people that identified as women, and so we're going to go with that. But just I wanted to say that not to exclude anyone from what we're doing, because we definitely want to be mindful of people in all communities who might be giving birth. So when we think about addictions in women, the percentage of people with addictions who are identifying as women is growing in the United States and worldwide. And most of these people who are diagnosed are between the ages of 18 and 29, which is like a peak time for reproduction and people being pregnant. Also, women tend to progress more rapidly from first use to actual diagnosis of substance use disorder, or maybe not diagnosis, but it becoming a problematic use. And there is a greater prevalence of polysubstance use, so using multiple substances, and of psychiatric comorbidities. And then many of the people diagnosed with addictions or suffering from substance use disorder have a history of trauma that needs to be acknowledged when we're treating them. So what about polysubstance use? It is extraordinarily prevalent. If you include tobacco and nicotine vaping products, we're pretty much at 100%, at least when people enter treatment. I mean, the data says 92 or 98%, but it's, in my personal experience, it's closer to 100%. And then if you look at cannabis, also, of course, growing, we don't have it legalized in Indiana, but Delta 8 is readily available, Delta 9, Delta 10, all the deltas are very available in Indiana. And you guys are pretty close up here to the region, so you're getting it from Illinois, we're getting it from all other states down in Bloomington. So it's very prevalent, and people don't really see it as a problem, they see it as natural. So lots of underreporting as well. And then amphetamines continue to balloon, the use of that is growing and growing. Opioids we haven't really turned the tide on opioids. In fact, we're seeing more and more fentanyl coming in, xylazine now, which is a non-opioid actually. But the rates of people with polysubstance use, this is ended in 2016, but this is looking both at rural and urban counties, and you see that in both areas, this is looking at pregnant people with opioid use disorder who were using additional substances, and the percentage of use of opioids alone is increasing, but the polysubstance use is increasing even more. Amphetamines is changing at the fastest rate. My guess is that this is before a lot of the cannabis legalization. My guess is the more recent studies would have even a lot of growing with the cannabis. Although some of these studies that are done on people with opioid use disorders are done in people that are in treatment with buprenorphine and things like this. So sometimes the rates of cannabis in those populations are lower than just like incoming to the treatment initially. But psychiatric comorbidities, the range is really large in part because there's a lot of underdiagnosis of psychiatric comorbidities. There's many places that provide treatment for people with opioid use disorder and other substance use disorder don't provide treatment for mental health, and so they actually don't always diagnose it. But the reality is it's very prevalent for people to have additional diagnoses, which can complicate their treatment, but isn't necessarily actually mean that they'll drop out sooner. It just means if you address it, that's what these studies showed, is if you address the mental illness, sometimes people are actually more likely to stay in to complete. A lot of times they are more used to being in treatment, they have a higher perceived need for the treatment, and sometimes they were using the substances to try to cope. So when you give them other ways to help them cope, they have less need to use the substances. Trauma, we're going to hear a lot more from Michelle on this later, so I'm not going to spend a whole lot of time, but it will come up a couple times in my talk, because especially when we think about maternal mortality, trauma is a big player for people with substance use disorder. And it's not just birth trauma. A lot of us think about birth trauma when we're working perinatal populations, but folks coming in with substance use disorder have experienced every kind of imaginable trauma, from childhood to incarceration to intimate partner violence to everything that you can think of. Of course, we know that early life adversity, the ACEs that hopefully people are familiar with, lead to both immune, neuroendocrine dysregulation. This puts you at increased risk for potentially using substances and puts you at even higher risk for that use to become problematic or a disorder. This is from our data from the Maternal Mortality Review Committee, which we're going to talk a little bit more about that. And something that came up that we weren't expecting is the high rate of involvement with DCS for people that were deceased during their perinatal period. So first of all, 65.2% of people, this is not people who died from things related to substance use. This is just of everyone who died in Indiana. 65% of poor women who were perinatal, not everyone who died in the state. So 65% of those folks had some form of involvement with DCS. And then when we look specifically at involvement as an adult versus as a child, so as a victim, but 8.7% were involved in both. So obviously having that involvement with DCS and that fear is something that creates barrier in terms of people being able to tell us what's really going on in their lives. And just to highlight, here's something that they said they felt there was a scarlet letter. And if we look down to here, where is it? Here, there was a fear of child protective services. I'm so stressed trying to keep my ducks in a row, keep CPS away. So it is a significant barrier for people in terms of accessing treatment. And if we, for all of us who, I feel like all the social workers taught me about this. I didn't learn this about medical school. This was like social work taught me this after I graduated. But if you don't get this, I don't really know how you can take care of people with substance use disorder, right? We got to take care of the bottom first. If we think about our, right, this is this part over here. Everything was a chaos. My boots, coat, everything got stolen. How can you focus on your treatment, you know, when you have no basic anything? And so we gotta move all the way up if we want people, oops, that's fine. If we want people to be able to get into recovery. So another another way to think about this, these are some of the barriers that people feel fear or exclude. Stigma, obviously, that's the scarlet A. Decreased perceived need for treatment can be a problem. Fear, DCS, racism, of course. Major problem when people are accessing treatment. We know that minoritized populations are at even a greater risk of not being able to access treatment or not feeling included or seen when they try to access treatment. Okay. So this is from Mishka Turkland, who's a gynecologist and researcher in the field of addiction psychiatry, of addictions in the perinatal period, looking at substance use and how it changes across the pregnancy, right? So the beginning, people are very hopeful, right? They find out they're pregnant, they're like, okay, I'm gonna change my life. They are able to do that in the first, second trimester. It's dropping how much they use. But then the baby's born, and like I said, fourth trimester hits, things are not as expected, problems start to happen, and people start to use more. This is just showing, this is overdose risk, so this isn't actually use, but we'll get to another slide on use, and it of course mirrors this. And this is the rate of overdose related to either pharmacotherapy or like heroin, fentanyl, not prescription pills. So both are rising. Not all of those are deaths. Some of those are just overdoses where people survive, thankfully. This is from our maternal mortality review committee. And you see our #1 cause of death. This is 2018 to 2020. The #1 reason that people are dying in Indiana during their pregnancy or 1 year after are overdoses. Followed by homicide. Many of these involve people who had substance use disorder, unfortunately. And then suicide, which again, having a substance use disorder increases your risks for suicide, as does obviously mental illness. When we look at when people die from overdose, it was in the late postpartum period. So from the end of a little bit after the end of the first month postpartum to the late year. This is data from Indiana, but this is seen all over the United States. This is the slide I was talking about when it looks at substance use. So this is a non-pregnant person in the red over the same year, so like a control person, just to show it wasn't just a year where a lot of people stopped using drugs. And this is the graph again of substance use for people that were pregnant. And so something to note is their use at the end is higher than the use of people that were never pregnant. And this is, it's also true, I don't have the slide in here. I'm doing a different talk in California, so I think I forgot to put the slide in here. But if you think about it, being pregnant is quite a risk for death, right? And that's even more for our people who have substance use disorder. So I think the risk of death for a person, a woman who's not pregnant, so the red line here is something like as likely as being struck by lightning compared to the risk of death for a person who's been pregnant. So even though the perinatal period is a moment of opportunity to get things right and get in recovery, et cetera, if you're not able to get in recovery, your risk for death is greater than if you had never been pregnant. So I think that's really in the same period. So I think that that's a very important thing for us to think about. It is such an opportunity and we're squandering it. Like the patients aren't squandering it, they're trying, to get better. We just aren't always providing everything, our system, not just us as individual people. We can try really hard, but if those basic needs aren't met, it's very difficult for people to be able to get into recovery. this time, but we'll get there. So fourth trimester, I'm gonna go kind of quick, but just a reminder together, I'm sure Bertie will cover it at her talk, but it's a hard time. It's also the time when obstetricians and other midwives, everyone who's taking care of you, are backing off, right? Your baby's been born, they gotta take care of the other pregnant people. They're gonna see you one time at 6 weeks, and then you're gonna be kind of on your own. So that's an opportunity for those of us that are not delivery babies. When they've asked people in focus groups who use substances, why did you stop going, you know, to your postnatal care? So these are people that had been attending, and this is a group out of North Carolina. It's Dr. Snoopy, who trained where I trained, she's an obstetrician, but she says her main wish in life is to be a midwife, even though she's actually an OB, so she's pretty cool. And I mean, OBs are very cool too, but she's a very cool one. But one of the things that I like to highlight in my talk is that this is a big reason why people discontinue care, is that they feel uncomfortable about how breastfeeding and sleep are discussed by the doctors, because it's very black or white. Like if you co-sleep, you're a bad parent, especially if you co-sleep and you have substance use disorder, you're a bad parent. And if you don't breastfeed, you're a bad parent. And people are sometimes doing a mix. You know, they're not trying to co-sleep, but they're falling asleep with the baby. They have other children. They're just doing the best they can culturally. Perhaps it's something that is meaningful to them. So instead, if we could have a way of talking about it that was like, don't sleep in a chair, right? Or in a easy, lazy boy type chair or a couch, because the baby can get entrapped. But if you have a mattress on the ground without pillows, and you're not using any substances, and your other kids are on other surfaces, that would be a way to do it to be safer if that's something that you're gonna do anyways. So being able to be more real about what people's real true realities are like would keep them coming to treatment. And that's what they said. They said when the providers give these very black or white, what's good and what's bad, we don't want to go there because we don't want to be judged. We don't want to be turned into to DCS. And for brown and black persons that were responding to this survey, they were particularly worried about being turned into authorities and highlighted that in particular as something they were worried about. This is another survey, same kind of question, why did you stop going to treatment? And this one talked about people really highlighted how I see myself and how I am seen by others as the two big things that sort of weighed upon them and made them hesitant to continue coming in. So this is, sorry, anyone who went to my labor of love talk or any of my other talks, this is one of my favorite slides, I always include it. And it's a cascade of self-stigma. So how does this happen, right? We know that if you've worked with anyone or if you are a human, right, you have some self-stigma, there's something about yourself that you rather the rest of us not know. And so for people with substance use disorder, that's very problematic for them. So it starts with just knowing that other people see you grew as a kid, no one was like, well, I'd like to grow up to use substances. Like that's not your goal. And you know that that's not looked upon very favorably. So you were aware of that, you start agreeing with it. Then you apply it to yourself, like I'm using substances, I might be one of these dangerous bad people, and then your self-esteem starts to plummet. And so you don't really feel very worthy of care, right? And now you're pregnant and you have a substance use disorder, so you really are not feeling too good about yourself. And maybe you've done this before, like you've tried before to be pregnant and get into recovery, you haven't been able to, and now you're like, it's about to repeat itself. And when we think about self-stigma and isolation is one of the things that is particularly dangerous when you have substance use disorder. It's one of the reasons why deaths from overdoses have risen so much during COVID, right? Many more people died from overdoses from opioids during fentanyl during COVID than died from COVID. And I didn't highlight that on that slide, but there was 3 deaths at the bottom there from COVID, and there were 67 from substance use disorder of people who were isolated, couldn't go to their groups, couldn't get their treatment. And as a healthcare system, we impose a lot of stigma that adds to the self-stigma of the patients, leads to more isolation, untreated use, and overdose. And empathy and positive regard can really help to move things the other direction. So as I've been highlighting, connection really is the anti-addiction, like people say. I don't know that I love the way that comes across, but it is a really important factor, right? We've got to bring people in. This is what they said in their own words. My doctor stood by me even after my pregnancy. That was really important. And then I kind of covered it over here, but there's a lot of positive things that they said about their providers. And then non-judgmental support makes a difference. You may or may not agree with what people are doing. That doesn't really matter, actually. Like, what matters is, what do they want? What are their goals? How do we find a way to move people forward? I always, when I'm feeling like, oh man, why does this person keep doing this? Like, I'm trying so hard. Why are they not trying? I try to think about, well, number one, I try to think of that image, right? Why are they not trying? They might be trying, but there may be all these things that I'm not thinking about. In particular, I think of this little figure here of people trying to get there without proper transportation. But I try to think of like a habit that I've tried to break that I can't break. Maybe it's not that. And then I think, if you think about how much drugs give dopamine to your brain, right? It's like astronomical. I need to put a chart of that back on here. I used to have that. So think about that, and then think about something like maybe you've tried to not eat as much chocolate, right? That can be a big one for me because I love chocolate. And it gives you like this much dopamine, and drugs give you that much. And if chocolate's around me, I'm probably gonna eat it. And it's this much dopamine, and they're getting this much, right? So it's our expectation that people are gonna be around drugs, which we know that they are in our communities all the time, and they're not gonna use them, is pretty unrealistic. And what should be really impressive is how much people do, walk through rain and avoid substances when they're just so readily available. But there are things that we can do. I'm gonna try to leave on some hopeful notes. I'm mostly gonna talk about the medical system. I think at the individual level, we're really, the biggest message that I can say is, unconditional positive regard. It does not matter what you think. It doesn't matter how many times people quote unquote mess up or don't follow the treatment plan. Just go back to the drawing board and figure out, get more help, get more community for yourself. So we all get really burnt out, get all the people in the room that can help and start again and replan. So I'm going to focus on the medical system. The government is absolutely extremely important. And we need fair housing, food, childcare, transportation. Without this, it makes it really, really quite difficult for the rest of us to do our work. We have been super fortunate, I think, with the Medicaid expansion. I think that's helped me. Pretty much virtually everyone that I'm seeing now is at least eligible to be on that, and it's, they can have it for a whole year. Definitely changed my life in terms of being able to care for people. But I don't know if you guys have the same problems here. We have a lot of fair, safe housing problems in Bloomington. They keep building housing there for the students, which is great. I mean, they need it too, but there's other people who are not students who also need to be housed. So transportation, our buses, we have a bus system, but it's very inefficient. Childcare, huge problem. There are some solutions for people with opioid use disorder. There are the vouchers, and we'll talk about a program that's helping with that, but still we need more of it. Medical system, it's siloed. If you're not a psychiatrist, you may not think, even if you are a psychiatrist, actually, let's be honest. If you're not an addiction psychiatrist, you probably think that addiction is not your job, right? Have somebody else see them. And obviously that makes no sense because that is a part of their life. They're not gonna take your heart medicine that you're giving them or do anything else if you haven't helped them with their addiction. So very siloed, people don't talk to each other, patients get turned away, they get inappropriate treatment, they get told things that are not accurate. I had my patients sometimes have to tell their OBs no, that is not true. For example, one OB told my patient recently, your baby's definitely gonna have withdrawal because you're on so much buprenorphine. She was on a low buprenorphine dose, and also, by the way, dosing, withdrawal from opioids from buprenorphine has nothing to do with patient dosing, which she knew. So she said, well, that's not accurate. My dose is low. And withdrawal for infants has nothing to do with maternal dose. And so he was like, sorry, what did you say? So you do have to empower people because doctors aren't always very knowledgeable. So these are some strategies to make doctors more knowledgeable. Oh my gosh, I did not even expect to say that little transition. That was good. So these are three that I'm involved with. I don't work for this part, but I advertise for them. So Project Echo, if you haven't heard of it, get your phones out, because you're going to get to register right now to participate in this. Project Echo through Indiana University. Notre Dame can also have it, no competition, like join us. It's a wonderful, wonderful project. It basically has all these different tracks, which you'll see when you register. There's like a peer recovery coach track. There's just every track. For anything you do, there's a track for you. And it's funded by some grants and by the state. And oops, that's all I have. Okay, so I'll explain it without more slides. There's like 6 slides, but we'll go with this. It's a 1 hour program. It happens every other week, or every week, depending on how many tracks you decide to sign up for. And it's a 20-minute, 15-20-minute didactic, so a little teaching. Then people from the community are welcome to present a case. And then there is 15 to 20 minutes for the group to discuss and give some recommendations. You're also mailed recommendations through like an email from the organizers telling you what we recommended. And it's not just the expert, quote unquote, people recommending, it's the whole community. And we all learn so much from each other. So like very very practical recommendations of what you can do with your case. Sometimes we don't know what we can do, but at least you got to hear that the rest of us also didn't know, didn't have a better answer. So just a great opportunity. And yeah, so join us for this. Look up which track you want to do. I'm on the perinatal OUD track, obviously, and then I'm on the peer recovery specialist track. There's another track that I sometimes do. I think it's not running right now, and I don't even remember what it is, but there's a lot of tracks that you can be on. So this is intensive case management. This is the Indiana Pregnancy Promise Program. I hope everybody knows about it, but you can register your patients through the phone number, or there's a website. It is for people with opioid use disorder. They have to be pregnant or early postpartum. And it is for people who have Medicaid. So it's Medicaid intensive case management. The folks that work this line are all awesome. I've known them. They attend the echoes. If you go to the echo, you'll get to know all these case managers because they're all on there and they're very wonderful. And one of the things that they have right now that's super cool is, if you've heard of Katie vouchers for getting childcare, they have easy access to those vouchers right now. So if you need childcare and you are pregnant or postpartum and have opioid use disorder, there's extra vouchers or designated vouchers for you. So a really great program. They just help with everything: transportation to your program, prior authorization, just everything. And they are able to, because they work for the insurance, they can see everything that you're doing and everything that you could do that you're not accessing. So it's pretty cool. And like I said, they're very committed people. A lot of them have been case managers for Medicaid for a long time. If your person you're working with does not have an opioid use disorder, there is still high-risk case management for them. And this is the slide with the ones for each different insurance. I never used to know what these numbers were, and then we finally got them. Dylan and Carmen, who are here at our table out there for champs, they're in the back right now. They got an email with this, and this is the holy grail, people. I'm saving this, so take a picture. Any patient that you have that's pregnant or postpartum can have a high-risk case manager through Medicaid to help them figure out how to get things paid for and who to access. And this is them. And if you email them, they're super responsive. They'll email you back. They'll say, what is the member's name and number? Let's figure out, let's try to help. I've called from my office with the patient, because the patient will be like, they never called me. I don't know who these people are. And then we'll call them and connect them. They'll say, oh, that person's manager is Lizzie. Let's figure out where Lizzie is and kind of get you connected. Okay, so then finally, perinatal access programs. I left the best for last. These are programs that exist in 25 states in the US, and we have one in Indiana now. And basically perinatal access programs have 3 facets to them. They have training, referrals and consultation. Consultation is really the heart and soul of it. These are all the ones across the US, and this is our Indiana champ right here. I put it kind of over Bloomington, even though it's mostly Indy, but just to help me. And this is another wonderful QR, so you can register here. This one is, I will warn you, this one's mostly geared towards providers that actually prescribe. But if you don't prescribe and you have a specific question, you call in, we're not gonna hang up on you, Dylan and Carmen will still give you resources and help direct you in the right direction. But you wanna tell this to anyone that you work with who does prescribe prescriptions, because they can register, they can call us, and this is the process. They would call, Carmen and Dylan would answer the phone, they would get some information, basic information about what their question might be around. Then they would ask them, do you want to call right away, or do you want to schedule a different time? They would let me know, or one of my colleagues know that the call is coming in, and we would return their call and give them recommendations, and then also send them a little written description of what we said. Today we're talking about perinatal, and this is a perinatal access program. It also has a general adult. So if your patient is not pregnant and they're seeing a provider, who needs some help on their meds or doesn't seem to know what they're doing, you can recommend to the provider to sign up for CHAMPS and call us. So, in conclusion, I don't want to do too many conclusions because I want to give a few minutes and we're almost out of time for questions, but the main conclusion is substance use disorder in the perinatal period is a time of opportunity. It's also a very high risk time. So we have to take it seriously and try to engage people as much as we can, not drop them just because they're no longer pregnant, figure out the resources and really focus on the postpartum. Connection is the most important thing that we can do. An unconditional positive regard, I am borrowing that from motivational interviewing, obviously. I don't know if we've trademarked it or not. But that's where it's at. That's how we all want to be treated when we come in for help. It's pretty difficult, no matter what you're asking for help with, to admit that you have a weakness. So we don't really want to push people down when they're trying to do that. That concludes my talk. Of course, thank you to all the wonderful people that work with me, because I have to be in connection, obviously, with others to be able to do this work. And these are all the people that I get to be in community with to help me be able to do what I do. So thank you so much, and thank you all for listening. We do have time for a couple of questions, and we have a microphone and hand sanitizer if people want to talk into the microphone so I can hear them and everybody else can hear them too. Do you have a question?
Thanks so much, that was wonderful. So my question has to do with alcohol use.
Oh yeah.
So can you just say a few words? I know you probably need a whole session, but.
Yeah, alcohol use continues to be, of course, present in our population. It's not always a common co-occurring with opioids. Sometimes it is, but we continue to see continued prevalence. A very sad thing that can happen with alcohol is because it is legal. Sometimes people switch from opioids or other drugs to alcohol because they think they won't get in trouble, which is very sad because alcohol is more harmful to the development of the fetus than is opioids by a lot. Opioids are actually relatively benign for fetal development. They've tried to prove that it's problematic, and it's just not that problematic. It's a problem because people don't bring it up. And also if you do only urine toxicology screening and don't do verbal screening, you will miss alcohol often. Not 100% of the time, but you'll miss it. So you'll be unaware. So a sad story in that realm that I experienced back in the beginning of working in this field was an OB team that I was working with. And it was before I was trained or I could prescribe Suboxone, buprenorphine. So they just were giving the person short-acting opioids from the office to get them through. And they did. They stopped using other, like heroin and other things. And so they told the woman, okay, everything's going great, but we need to bring you in for an induction. We're going to have you have your baby now. And she was like, oh, okay, no problem. She said, I just need about 3 days because I'm drinking. And so I need to detox myself because I don't want to detox in the hospital. And they were shocked and they called me and they're like, how could this have happened? We didn't know she was using alcohol. We didn't do anything about it. So I think with alcohol, what's hard is it's not illegal. So people think they can use it. They also don't really want to tell you because they know it's not exactly the right thing to do. They're trying to do harm reduction themselves. They're trying to do something that they think is going to be less risky. They're not injecting, they're not going to get arrested for it. So I think it's just like with all other forms of polysubstance use or substance use. If you don't ask about it, people aren't going to tell you. I did a talk yesterday, which was all about screening. Like every single slide was like, oh, there's a screening tool for that. And apparently I decided not to do any screening tools today. I don't know how that happened, but there are the 5 Ps, which is the screening tool should be used for perinatal substance use disorder. It's a really, really nice screening tool because it starts by asking about the peers, the parents, the peers, the partners. Like, did your parents use? Do your friends use? Does your partner use? And a bunch of other questions. Have you ever used in the past? To kind of get people into a place where they can tell you. And from what I remember, it specifically asks about alcohol and gives like specific alcohol, like things you can say to people regarding alcohol. People might be aware of, if you have alcohol syndrome, but they may not know exactly what it is or what they need to do to prevent it, other than not drink, obviously. So I think using a tool like that is quite useful. And the other thing, of course, is you just can't tell by looking. People who use substances look like all of us. Like we all use substances. I drank coffee this morning. When I was in college, I went to college in Western Massachusetts. It was a very small town. And people in our college one day took away all the coffee served in the college. So from all the student centers and everything, there was no coffee. And you had to walk into the town, just like a little bit of a walk to get coffee. And people were freaking out about it. There was definitely a black market, like spring up immediately. And there weren't cell phones. Like I went to school in the 90s. So people had to go to pay phones and call each other and be like, bring me a coffee. It was so intense. Just remembering that, yeah. I went to the black sheet. My professor, who was my, advisor, was losing it. She said, "How is this possible?" I was like, "I don't know, ma'am. I'm not. You really need some help." Maybe that's why I'm doing addictions now, because she was my favorite professor. So I'm like, it's not such a big deal. It's just coffee. But she was really upset. So we all use substances. Even though, unfortunately, the people that die from substance use disorder tend to be more disadvantaged and have more trauma because they have less connections, less ability, not manifest, but to have the services available and get out of that addiction. That's not to say that there aren't people who are using who don't end up dying, who look like you might not expect them to look, right? So you've got to do a screening of some kind, or is that my alarm to say we need to move on?
One more question.
Okay, sorry. It's okay, they have like a little look on me, which is good.
My question is really quick. It's specifically about the Indiana Pregnancy Promise Program. It's a little bit client specific too.
Sure.
I have a client who just gave birth and she actually gave her baby up for adoption.
Yeah.
So are there any services with that?
Yeah, I think my understanding is she can still use the Pregnancy Promise Program because it's not dependent on the baby still being in your custody. Unfortunately, so many of the people we take care of are not able to parent right away. And yeah, it's not dependent on that. It's just dependent on when they give birth. Yeah.
Thank you.
Yeah. And it's totally free. I think that should be obvious, but any other questions? Don't be shy.
Sorry, no, keep asking. So I worked as a pediatric nurse practitioner for many years with an underserved population. And one of the things, there's such an adversarial kind of dynamic between those who care for the mothers and those who care for the children.
Yeah.
So how can this dynamic change?
Yeah.
Another little tiny question.
Well, we did on one of our echoes. Oh, that's the echo that I was on, the IPV. We had like an IPV echo, an echo about intimate partner violence. And we dealt a lot with child abuse on that one too. And we brought in a child abuse pediatrician to be one of our advisors. So I think there is often this idea of like mom versus baby, which we really want to think more about it like a dyad. I mean, while they're pregnant, you definitely can't separate them. You can't just take the fetus out and put it on life support and have it like live independently. I know we're in a state where people think you can do that. You actually can't do that. You have to keep them together. And once they're born, yes, sometimes they can't parent them right away, but that doesn't necessarily mean that they're, that they are adversaries, because they need each other. Especially the baby actually does need the mother. And we don't exactly live in a place that has so many available other parents that are ready to go. And, there's a shortage of that as well. So we can't solve this problem by doing a parentectomy, right? Like as a pediatrician, I'm sure you were aware of that. Many times it would have been much easier to separate the annoying parent from the child. And being a parent myself, I'm sometimes like, my kids would have a lot less problems if I just got my act together, right? So I'm sure my pediatrician thought that. I know he did, because he would just start laughing at all my questions. And I was like, I'm anxious about this right now. Please stop with the laughing. So I think what we've done in our community, first of all, our pediatricians were the first to screen perinatal people for depression. They were doing the Edinburgh depression scale way before obstetricians even knew what it was. So we had that to help us. But when it came to substance use disorder, they had a very different feeling, where the feeling about depression was, oh, this person has an illness, they're depressed, they want to take care of their child. Whereas with addictions, it was like, well, this person's just morally bad and they're going to abuse their child. So I think trying to bring them into the fold, the pediatrician, and meet with them, which we do. And so our patients would say, like, I go to the pediatrician and they just treat me terribly. They think everything is from the opioid withdrawal. And my child is like 7 months. I don't think they're in withdrawal anymore. And I was like, no, I don't either. And also your child never had withdrawal, so they're definitely not still in it because they never had it. So we tried to talk to our peds leadership, and then let's get together, let's talk. What are you worried about with all this? How can we help? And they were like, we don't know what to do with them. They're going to hurt this child. There's been fatalities and different things. And we're like, yes, that can happen. What can we do to help you guys? If you identify a problem, can you call us instead of, not addressing it? And that's been helpful. The problem with fentanyl right now, of course, has been a huge thing in the NICUs, in our NICU at least, because we're testing moms with urine screens and the fentanyl doesn't show up in the screen. And so they don't know that there's been this exposure, but then if for whatever reason they test the baby's cord, then it does come up positive because they're using a different kind of screen, but that baby's already left the hospital and didn't get monitored properly. So the pediatricians are very worried about this, understandably, and that's actually brought them in discussion with us of trying to figure out how do we screen better, and they're interested because of the baby, but it's really highlighted like this ability for us to work together. It's like a mutual problem. But I do think pediatricians often can feel very adversarial because they're trying to protect their baby, their patient.
Dr. Arnaudo, thank you so
Yes.
much for being here today and for sharing the resources that we all have access to. So it's a super important topic. Thank you for being here. And go ahead and get us going. So I'm delighted to welcome our next two speakers, Dr. Jasmine Johnson and Dr. Michelle Miller, who will be speaking about bridging health equity to clinical practice in perinatal mental health. Dr. Miller is a clinical psychologist specializing in clinical research at the intersection of women's health and traumatic stress. She's an assistant professor at the IU School of Medicine, Department of Psychiatry, and developed the Perinatal Trauma Stress Lab. The lab recruits pregnant and postpartum women with a history of trauma and PTSD symptoms to participate in individual and small group interventions, including those who are rarely included in perinatal traumatic stress interventions, such as racially and ethnically minoritized individuals, women in recovery from substance use, and rural patients. Importantly, she has implemented a PTSD screening protocol in high-risk obstetrics clinics that serve a large proportion of Medicaid recipients and racially and ethnically minoritized women. Dr. Miller is currently grant funded to implement screening for trauma exposure and PTSD symptoms in both rural and urban perinatal populations. She has also established the IUSM Traumatic Stress Clinic, which provides clinical services to anyone in the IU health system struggling with mental health sequelae following a traumatic event. Further, she created a training curriculum alongside the Traumatic Stress Clinic for clinical psychology trainees to learn assessment of and evidence-based treatments for PTSD. She is also currently grant funded to create a training curriculum for IUSM students on how to identify and discuss mental health and experiences of discrimination with perinatal patients. So welcome, Dr. Miller. And Dr. Jasmine Johnson is a wife, mother of two, and assistant professor of obstetrics and gynecology in the Division of Maternal Fetal Medicine at Indiana University School of Medicine. Jasmine received her undergraduate degree from the University of Michigan, medical degree at Indiana University School of Medicine, and completed residency and fellowship at the University of North Carolina, Chapel Hill. Dr. Johnson's research interests include health equity and using scientific rigor to demonstrate the downstream effects of racism on pregnancy outcomes. She strives to be a fierce, evidence-based advocate for the historically minoritized populations of her community and nationally. We'll save the questions for the end, but welcome as well. Thank you.
We're going to talk about trauma and disparities in the perinatal period of trauma-informed response. No disclosures, no disclosures, and our funding is below 4%. These are our learning objectives. We'll talk a little bit about perinatal health disparities, experiences of discrimination, healthcare, as well as then talking about trauma exposure, PTSD symptoms, how it presents, and how to screen and discuss these experiences. All right, I'm so excited to be here. Thank you so much. I'm Jasmine Johnson. So I'm a maternal fetal medicine doctor. So that means that I take care of people who come into pregnancy with a complication or develop that, or we diagnose a complication with their pregnancy. And so this can be a very high stress situation. I always like to start my talks kind of with positionality. So I'm a mother. I identify as a Black woman. And so the things that I'm going to share with you today are very personal to me. The Black maternal health crisis in our country is a life or death situation for Black birthing people in our country. And so it's really important for me to kind of share with you some of the information that we've developed in our curriculum as we continue to train future OBGYN physicians and future psychologists and psychiatrists how to address racism in perinatal health. Also training at UNC. So after Dr. Arnaudo mentioned Dr. Stupi, she was actually one of my faculty mentors, and she calls herself a maternal fetal midwife, so I still learn from her all the time. So we talk about health disparities. I think we throw this out there a lot, but a lot of people may not know what exactly a health disparity is. So the National Institute of Health defines a health disparity as one in which there is a significant disparity in the overall rate of disease prevalence, morbidity, or mortality in the specified population as compared to the general population. But we don't just see disparities in healthcare. I think that's something that's really close to our hearts and what we do here. But there are disparities all around us with regard to race and ethnicity. So what do we call a disparity in economic resources between white and Black communities? That's been referred to as the wealth gap. What about disparities in education-centered outcomes like standardized test scores? That's been called the achievement gap. What do we call a disparity in Black and white rates of imprisonment? Well, some people refer to that as the school to prison pipeline in the Black community. This figure comes from the Race Equity Institute workbook, just to give you an idea of what Black-white disparities look like across systems in our country. Race is a social construct. It is not biologic. And I think it's so important for all of you to leave this room knowing that, because what that means is there is no genetic reason for why we have these disparities. There is nothing inherent about me as a Black person that says that I should have poor outcomes. It's just the color of my skin and how that affects my potential in the larger system. So I strongly encourage you all to consider taking the Racial Equity Institute groundwater training. They start their session with this story, and I think it's so brilliant. So if you have a lake in front of your house and you walk past the lake and there's one fish belly up dead, we look at that fish and we say, what's wrong with that fish? But if we walk past that lake and all the fish are dead, we change our thinking and we say, what is wrong with that lake? Why don't we do that for people? I think that we should be thinking about health disparities this way. Health disparities will not be eliminated if we just focus on what's going on in the hospital. I would argue that these are links, all of those systems. We have to examine groundwater. So this table is taken from the American College of Obstetrics and Gynecology Committee Opinion on Racial and Ethnic Health Disparities. As you can see, Black patients are more likely to experience infertility, have higher rates of preterm birth, Black infants have a higher infant mortality rate, and Black birthing people have a maternal mortality rate that is 3 to 4 times that of their white counterparts. Think about each of these disparities in our field, and what we've been told is the why. Was it the fish or the lake? Today is going to be very broad strokes, and it's really a Cliff Notes version of an hour-long lecture I could give you. But I encourage you all to leave here today and continue to do your own research. And then also, because I will forget to say it later, the lack of data we have on American Indian and Alaska Native populations and Asian populations is also a form of racism by exclusion. So we have to figure out who is doing the research and not tracking outcomes by race and ethnicity for all. And why not? Because we can't fix disparities that we're not measuring. If you're not familiar with this piece and are looking for a great starting point on the overview of health disparities in OBGYN for Black women, this is it. My favorite line from this paper and how I preface my talks: enough is enough. Race is a social construct, and the overwhelming statistics we present are attributable to a broken racist system and not a broken group of women. Evidence-based outrage is the objective. So in order to understand racism's impact on health outcomes, we have to understand kind of what the different types of racism are. So Dr. Camila Jones is the inspiration behind the groundwater analogy and how systems perpetuate inequities. And she talks about 3 types of racism in this paper: institutionalized, personally mediated, and internalized. Institutionalized racism or structural racism is defined as differential access to material conditions and access to power. Dr. Jones writes that it's important to note that the association between socioeconomic status and race in the United States has its origins in discrete historical events, but persists because of contemporary structural factors that perpetuate those historical injustices. And for Black birthing people in this country, 1619 was the initial historical insult. It set the stage for structural barriers, societal norms, and biologic determinism. When the first enslaved Africans arrived in this country, their humanity was removed as a means to justify the horrible treatment they were subjected to. This is a photo of Dr. Marion Sims. He was lauded as the father of modern gynecology. The Black woman in the photo is one of the enslaved women that he used to perfect his surgical techniques on without anesthesia before performing his surgeries on fully anesthetized white women. Lucy, Betsy, and Anarcha are the 3 names that we know, but we know that he did this to many more. And the reasoning behind was that it was thought that Black or enslaved Africans did not feel pain. It seems extreme that we could go back there, thinking that Black patients have a higher pain tolerance than white patients. But the following studies demonstrate how insidious this historical institutional racism is. So the legacy of these false beliefs was most apparent in a 2016 study at the University of Virginia that examined biases in assessments of pain scores in both lay people and medical trainees. So they looked at medical residents and nursing students. The statements that they were asked to confirm are listed in the left. And so they had to say if these items were true or false. And one of those items was things like Black people's blood coagulates quicker than whites, or nerve endings are less sensitive than whites. And what they found was that up to 75% of participants in the layperson group and up to 50% in the medical trainee group endorsed at least one false belief about Black individuals that could affect their clinical assessment of a Black patient. The figure on the right just shows that with higher false beliefs about Black patients, there was a lower proportion of accurate treatment of Black patients. And what does that look like in a clinical context? So during my fellowship at UNC, under the research mentorship of Dr. Subi, we performed a retrospective study over a 2-year period of people who just came in for a low-risk cesarean delivery. And we sought to determine the extent to which the frequency of pain assessments, pain scores, and medications administered differed by patient race and ethnicity after they had this low-risk procedure. And the reason we chose a low-risk cesarean is that our hope was that everyone's pain needs would be very similar. Based on other pain literature, we did hypothesize that there would be inequities in how pain medications were administered. So the following figures come from table 1 of our paper. And so you'll see that it's divided into 2 time periods at 0 to 24 hours postpartum and 24 to 48 hours postpartum. And then for the purposes of our study, we used non-Hispanic white patients as the reference group. So you'll see them in blue. And then anything that's a statistically significant difference is noted in red. So for this figure, we looked at severe pain or having a pain score greater than 7. And we found that it was more commonly reported among Black and Hispanic patients than among those who identified as white or Asian. And we saw that at both time periods. And then when we looked at the number of pain assessments received by staff, compared with non-Hispanic white patients that are noted in blue, non-Hispanic Black, Asian, and Hispanic patients, all in red, all received fewer documented pain assessments. And this was statistically significant at both time periods. And then compared to non-Hispanic white patients, we saw that non-Hispanic Black, Asian, Hispanic, and patients who identified as other all received less opioid pain medication at 0 to 24 hours postpartum and at 24 to 48 hours postpartum. And then with respect to non-opioid therapy or NSAIDs, we saw that at 0 to 24 hours postpartum, non-Hispanic Black patients still received less NSAID medication. And then at 24 to 48 hours postpartum, there was a statistically significant difference for Asian and Hispanic patients. And so from this study, just as we hypothesized, the experience, assessment, and treatment of pain differed by race and ethnicity. And as you can expect, our units were really, really floored by this result. This was our hospital, and we all really felt, committed to the mission of not perpetuating inequities. But I think that this speaks to how biases and just those quick ways that we may triage certain patients over others can show up. And so that's why it's so important to capture data like this. So another outcome that's really important as a high-risk obstetrician is preterm birth. Preterm birth continues to be a source of significant neonatal and maternal morbidity in the United States and worldwide. And as stated before, it's one of the primary drivers in racial and ethnic disparities of perinatal health. And we know that the preterm birth causal pathway is very multifactorial. And there's some awesome work being done looking at the role of structural racism in perpetuating some of these disparities. For example, redlining is a historical practice by banks to not give housing loans to Black families in certain neighborhoods in an effort to keep them segregated. Redlining, although not practiced today, still has had generational consequences for perpetuating inequities in Black homeownership and generational wealth. In this study out of Chicago, they looked at a population of over 4,000 non-Hispanic Black women at a single urban medical center. And what they found is that for those who lived in neighborhoods with high racial segregation, so just more homogeneity with respect to race and ethnicity, the prevalence of overall preterm birth was significantly higher than that in areas of low segregation. And they saw this relationship for both medically indicated and spontaneous preterm birth. And then when we look at injustices in the US carceral system, they have their evolution from slave codes and Jim Crow. We know that today, 1 in 3 Black men have a risk of imprisonment over their lifetime compared to 1 in 17 white men. This study out of Detroit looked at neighborhood mass incarceration rates and future preterm birth risk among African American women. And so they linked basically prison expenditures with medical record data. And they actually found there's an association between prison admission expenditures and future risk of preterm birth. And they saw that risk highest in those group of people that were younger than 35 years old. I really love this figure from this paper. So I think that this also just puts into perspective what the history of being Black in America looks like. And the majority of our existence here has been slavery and segregation. So only 14% of, Black people in America is in that free quotations, and that it's post kind of the civil rights act. And then with respect to infant mortality, because we also care for the babies, Wallace et al. Found increasing measurements of structural racism defined as racial inequity or ratios of Black to white population estimates in education attainment, median household income, employment, imprisonment, and juvenile custody were all associated with Black infant mortality. So specifically across all states, this was kind of a national data set, they found that increasing rates of racial inequity in unemployment was associated with a 5% increase in Black infant mortality. And they conversely found, which I think is really encouraging, decreasing racial inequity in education was associated with an almost 10% reduction in the Black infant mortality rate. So I think that this goes back to what we were talking about in the beginning and looking at systems as a whole. Because if we're going to undo all of these inequities and disparities, we have to start outside of the clinical spaces. So despite racism being named a public health crisis by multiple organizations, including the American Public Health Association, clinical tools to screen for racism and its effect on health remain limited. So in the prenatal care model, we don't usually screen for racism. And so that's how Dr. Miller and I got connected, because I think it's really important that we start to address racism in prenatal care and in over the life course of our patients. And so one tool that has been used in the past is the Everyday Discrimination Scale. So this is a screening tool that was developed in 1997 by Dr. David Williams, and he is really one of the founding fathers of screening for discrimination. And it's a validated tool, so there are a number of iterations of it, but this 9-item scale is kind of the first one that came out. And what they found in some of the validated studies is that the Everyday Discrimination Scale is highly correlated with psychological distress or stress if someone scores concurrently with having high levels of discrimination. And so it's kind of reverse scored. So if you have more frequent episodes of discrimination that you're reporting, you get a lower number. And so this is something that we've started to pilot in our outpatient prenatal setting, just to see if it's feasible. I know that when someone comes for a prenatal visit, there are a lot of screening tools, there are a lot of interviews, and so we don't want to add to the burden that patients have of all the things that they have to do when they come in, but I think this is a really important tool, and so far we're seeing that it can be done very quickly. And again, just to underscore why it's important, so this study came out of the Green Journal, which is kind of our OBGYN, it's the journal today. But it was last March, and it's a qualitative study. So they interviewed Black women over the course of their lifetime, and they just wanted to know what it was like seeking reproductive care, what their experiences were. And even for those who might not have had an experience of discrimination directly, they had vicarious experiences. So they were telling the stories of their mothers and their grandmothers, and that in turn determined their decisions and how they chose care providers and whether or not they chose to have children and what type of contraception they chose. And so it may not look as blatant as someone saying they were directly discriminated against, but our patients are hearing this with them. And so again, I think it's so important for us to start engaging them in these conversations. And so this is just an example vignette, because I feel like this is a combination of a number of things I've heard from patients. So AC is a 27-year-old G2P1001. She's 11 weeks and presents for her new OB visit. She appears hyper-aware and very prepared for her visit with a notebook of questions. She tells you that she has read about Serena Williams' story and about a local doctor who died after her delivery. She tells you her last doctor was very rushed for every appointment and did not listen to her when she didn't feel her baby move. She ended up needing an emergency cesarean delivery and thinks if she had not come to triage, her baby would have died. She tells you she is so nervous about having a complication this pregnancy and does not want to die. And so that is what I feel like racism and stress looks like for Black women having babies today and Black working people. The joy of pregnancy is not there because they are just so afraid that every situation is laced with racism or that they're not going to be listened to. And so I think that we have to start talking about it. And so I'm going to leave you with a few tools that we found that we've incorporated into our curriculum that I think will at least help you start to feel comfortable talking about this. One of them is this document called Liberation in the Exam Room. And it's started by the Institute of Healthcare, it's like an Institute of Healthcare Quality. And so you can find it online. And so it is essentially like a one-pager, so you can distribute it in your clinical spaces or wherever you work. And it not only gives like a quick summary, kind of like what I went over today, but also just some conversation starters to start addressing experiences of racism in the exam room and how that may show up for our patients. And so some of the highlights from these documents are talking about identity. So first, just finding out how your patient identifies themselves, because their self-identity will help you to care for them better. Talking about their experiences in the healthcare system. So a lot of people have experiences that they have interpreted as them being discriminated against or as racism-laced experiences. And so I think it's really important for us to talk about it. I don't know how many times I can say that. But even in the maternal mortality narrative, when we go back and talk to families who have lost people, I think kind of the underlying thread is always no one listened. We said something and no one listened. And then talking about life experiences as well, because although they may not have had a direct experience within the healthcare system, as you can see from the data related to kind of the preterm birth disparities and everything else, even discrimination in other domains of society can have consequences. Asking relevant follow-up questions, and then just better responses and power sharing. And so I think one of the things that's really intimidating about this, and Dr. Miller and I talked about this when we were developing our curriculum, I think especially in OBGYN training, we don't do a good enough job of teaching people about how to counsel about mental health in general and screening. And so I just remember when I gave an Edinburgh to a patient as a resident, and then they scored high and endorsed thoughts of self-harm. And then you're like, oh, what do I do now? And that is something that we don't want our trainees to go through. We want them to feel empowered to have this information and then take it to the next level. This is another good resource. So this paper is called This Is Our Lane, Talking with Patients About Racism. And so the table 2 from that paper just gives you some suggested next steps. So I think it's really important for you guys to know that our patients aren't looking for us to kind of solve the world problem of racism, but I think they are looking for someone to believe them. And they're looking for someone to say, I am sorry that happened to you, and think about ways that we can help. So if it's, someone is being discriminatory on their job, then maybe we can connect them to social services. I think it's important to highlight on table 2, they mentioned consider a referral to psychiatry and behavioral health if the patient is amenable, because I think that racism is a stressor that needs extra support. And that's something that I hope we're going to start talking about more. And finally, taking a position, talking about how they didn't deserve what happened to them. And finally, just deep listening and again, reaffirming your role as a provider to get them and partner with them and to help them through. All right. So that's it for my portion. These are just some racial equity centered training. So Racial Equity Institute is what I talked about in the beginning. March of Dimes also has a great one, and the National Birth Equity Collaborative. Dr. Miller. talk a little bit about perinatal. Dr. Johnson, we're going to talk a little bit about perinatal trauma exposure. As Dr. Johnson mentioned, we're looking at both of these experiences in perinatal period, two things that tend to not get explored enough but are pretty common in these spaces. So when we say exposure to trauma, what are we talking about? Exposure to trauma is pretty common. About 70% of adults will experience at least one traumatic event, and it's not always something that involves abuse or emotional nature. Trauma exposure is essentially some of the things that are considered trauma exposure by the DSM-5, although it doesn't include everything, of course. But trauma exposure is considered something that happened to you personally, something that you learn about happening to someone close to you, or something you're exposed to as part of your job, such as a paramedic, military, first responder. So most individuals who experience trauma exposure experience some PTSD symptoms immediately after the incident, such as hypervigilance, replaying the event in your mind, and some avoidance around things that are reminiscent of the trauma, but then it is processed and fades. However, for some individuals, especially those who've experienced interpersonal nature, violence in childhood or adulthood, may continue to struggle with these symptoms related to trauma exposure and then be diagnosed with something that is called post-traumatic stress disorder, or PTSD. So what this slide is just saying a little bit about how common this actually is in the perinatal period. So about 3% of community samples meet diagnostic criteria for PTSD while they are pregnant, and that's comparable to rates of PTSD for adult females, which is about 4 to 5%. However, prenatal PTSD affects Black pregnant women at rates more than about 3 to 4 times more than white women, which is approximately 14 to 30%. And then in high-risk samples, we think of from going 3% in community samples up to 19%. We see the same disparity in the postpartum period. That prevalence tends to be about 3 to 4%, but high-risk samples, it can go up to 15%. And PTSD rates are higher for patients when certain risk factors are present, such as, of course, racial and ethnic minority status, history of physical or sexual violence, child abuse, severe fear of childbirth, diagnosed fetal problems, or severe pregnancy complications. And so not only can prenatal PTSD be prevalent, but higher rates of PTSD are associated with some of the poorest perinatal outcomes. And that includes preeclampsia, gestational diabetes, and increased rates of maternal mortality. So traumatic events associated with the diagnosis of PTSD during pregnancy and postpartum period are not limited to those that actually occur during the perinatal period. Often that might be what we hear about, like a traumatic birth experience, but it is not limited to those. So there can certainly be perinatal specific trauma, right? And that often happens when there is a traumatic birth experience, an unplanned emergent C-section, really when there's these feelings of helplessness or hopelessness, loss of control, fears that they may die during the birth experience in general, or assault during pregnancy. However, many individuals, and I would say often in my clinic, it feels like most of the individuals coming in for perinatal PTSD have a pre-existing history. And that can include a range of traumatic events, but they're often interpersonal in nature. And that could be during childhood, during adulthood, but and pretty universally in survivors of sexual abuse or violence. So overall, those with PTSD and trauma exposure during pregnancy and postpartum may be reporting frequent distressing physical symptoms, perceive their health as poor, they might be endorsing more health behaviors and more pain. Right? And this is the general overview of what we find, but I want to get a bit more specific about some behaviors that pregnant and postpartum individuals who may be experiencing with PTSD or have a significant trauma history, what that looks like. So when someone is experiencing this and you don't know if they have a trauma history or if they have a diagnosis or could be a diagnosis of PTSD, it might present other ways, right? In pregnancy, this often looks like not being excited about the pregnancy, feeling very anxious or upset, wanting to avoid thinking of the baby. It can be avoiding prenatal care to not experience triggers or have severe reactions during prenatal visits, such as when going through pelvic exams or ultrasounds. So during prenatal visits, they may feel upset, overwhelmed, and numb. Patients can experience strong memories of flashbacks of the trauma, feel out of control, or experience physical sensations or responses such as panic attacks, freezing, or dissociation attacks. And because of this, right, they may come in late for prenatal care, might be lots of no-shows, a lot of anxiety during the appointments. So you may also come across as anger or irritability, you may come across as kind of argumentative with front desk staff, might not want to fill out screens, might also be from this lack of acknowledging the pregnancy because of fear of removal. Dr. Arnaudo mentioned like there also is this comorbidity with substance use, so that also might be related to this wanting to keep things to themselves. And so if providers don't know of this trauma history, you might also use phrases commonly associated with pregnancy and labor, like relax, it'll be over soon, you're doing great. These phrases actually can be triggering and reminiscent of other things that their abusers may have said to them. So they're not knowing that this history is present. So during labor, trauma history also can be present and look like a lot of fear on delivery, especially this idea of this lack of control. We have a sense of dread, may kind of be just describing much, a lot of fear. There also can be dissociation, which is where essentially they're not emotionally present when they are experiencing flashbacks to the trauma, and they may be appearing to be kind of attending to other stimuli. In the postpartum period, what this tends to look like, again, can be a kind of continuation of the anxiety, but also can include things such as this lack of attachment to the child, difficulties bonding, worries of losing their temper with the baby, feeling like the baby doesn't love them or accept them, or really kind of just struggling with that transition into parenthood. And so if your patient is endorsing some of these behaviors, trauma history is indicated. So when we think of PTSD symptoms, again, not thinking just of trauma history, but thinking of kind of more clinically, they are classified in 4 groups. They're intrusive thoughts or memories about the trauma, their avoidance behaviors, try to stay away from things that remind them of the trauma, negative affect and cognitions, and hyperarousal, always going to be on edge. So in addition to knowing what this looks like in the clinic, it can also be helpful if you do know someone has a diagnosis of PTSD to know what this tends to look like in pregnancy and the postpartum period. So this is a graph from a study that looked at depressive and PTSD symptoms in a community sample of hundreds of, so it's mostly white, married, educated, financially stable Midwestern participants that all had experienced trauma of some kind. And when we looked at PTSD and depressive symptoms, and we looked at them 2 times in the postpartum period. The first around 4 to 6 weeks, right, which is usually the time that individuals may be coming in for a postpartum visit. They were, for those that were endorsing primarily PTSD, they were most likely to endorse avoidance behaviors such as really trying to avoid talking or remembering the trauma. Really trying to avoid talking about the trauma, as well as avoiding external reminders, right? Things that were connected to trauma, really trying to stay away from those. And for those that had PTSD and depression, they were more likely to experience an elevation in symptoms across the board, as well as appetite loss and diminished energy and motivation. So this changed a little bit at 3 months postpartum. So at 3 months postpartum, these groups tended to have comorbid PTSD and depression, or even primary PTSD with depression. But again, it was marked by higher symptoms across the board. And so that means if patients are describing symptoms of PTSD, that in this time point could also include a traumatic birth experience, such as not being able to move past the birth experience, not being able to forget some of the things that happened in the past, a lot of sadness, a lot of negative thoughts, a lot of avoiding behaviors, or feeling really on edge. This may actually be a combination of postpartum depression or PTSD and not just normal adjustment to the postpartum period. So how do we help trauma exposed perinatal patients? And knowing this exists, knowing this is common, what can we do? So we believe it's important to use a trauma-informed care lens when working with these patients. And at its core, trauma-informed care is a shift. Instead of asking what is wrong with this person, it asks all of us to take a step back and ask what has happened to this person. Being trauma-informed is this idea of this universal precaution, very similar to how healthcare professionals put on gloves when you come in contact with body fluid to prevent the spread of bloodborne pathogens. We don't ask, do you have this disease? It's just, let's do this just in case. And essentially it's asking us to put on these gloves by understand some of these events that patients may have experienced before the age of 18 and consider these 10 types of adverse childhood experiences. And for each of these, right, you essentially get a point for if you've endorsed one of them, right? If I said yes to one of these experiences, I would get an A score of 1. If I said yes to 3, I would get an A score of 3. So importantly, so there are several health outcomes. So not only just how this might affect perinatal period, but several health outcomes that have been correlated with higher ACE scores. And these higher ACE scores, individuals will actually have higher risk of negative health outcomes such as smoking, severe obesity, suicide attempts, alcohol and drug use, right? Things that also may be relevant in the perinatal period. So this infographic does a nice job describing these core components of this original case study. So this is what this questionnaire is asking about. It is asking folks to consider if they have and to report if they have experienced one of these 10 types of adversity before the age of 18. And this includes physical, emotional, and sexual abuse, physical and emotional neglect, and then 5 categories of household dysfunction, including growing up in a household where there was a caretaker had mental illness, a caretaker used substances, was incarcerated, a victim of violence, or divorce. So again, this can be something to help understand kind of childhood adversity. There is also a more formal PTSD screen, right? This asks about different types of trauma, have you experienced this, gives some common examples, and then asks about 5 symptoms that are commonly reported and typical of their cluster type. And this is actually one of the screenings that we use in our project to ask about trauma exposure and try to be as brief as possible. Also, if you're not able to use these tools, right, you don't have the bandwidth, don't have some ability to kind of help with this standardized screening, here's some examples of what to ask and what to say, how to ask and what to say. Right? Has anyone ever hurt you, made you do something that you didn't want to do when you're younger as an adult? Kind of more general, if you were noticing something in the room, you're uncomfortable during pelvic exams, you seem really anxious. Is there anything you'd like to know that make these visits more comfortable, as well as kind of a little more clinical, something that we use in clinical intakes, right? Have you experienced any physical, emotional abuse, or violence in childhood or adulthood? The most important point is to ask about it in whatever language that you can, and there are tools to do that as well as different ways. But as well as here's some. This came from a more recent about traumatic birth specific questions. And if people are coming into your office and they're saying you can't quite get past the birth experience, or they seem very uncomfortable talking about it, ask, right, what was your birth experience like? Do you wish things had gone differently? Are you having, and then kind of listing out some of the PTSD symptoms, are you having nightmares or upsetting thoughts about the birth experience? And something that in the literature too is like also asking and thinking about how this may not just come across someone saying, hey, I have PTSD, hey, I have experienced trauma. When individuals are coming in recurrently with babies that are well, and there is no problem, there's a lot of anxiety around like, what could this mean, or what could this mean? Is there something else underlying this anxiety? Is part of it not being able to kind of recover from some of these things? Right, and then one of the other things was to often think about, right, that there are comorbidities with the experience of trauma, and there are some other really good assessment measures that are out there that can have been validated for use with pregnant and postpartum patients, and kind of just listed some of the most common ones, right, like depression, anxiety, disordered eating is something that can be common, substance use, and partner use. So what do we say? Someone says, yes, I have trauma, I've experienced this, I'm struggling. Right? When a patient discloses trauma, it would be helpful first to acknowledge knowledge of past experience of trauma can affect their pregnancy, and that the patient isn't alone. Right? So that's helpful, right? Jasmine was saying, right, is to hear them, believe them, and let them know that this is a space where it can be discussed and talked about. Right? I hear it, and the lady is always going to do what the first thing that you think of saying, as well as like, what has it been like? Thank you for sharing it. He's normalizing it. This can happen. You are not the first person. You're not alone. This happens sometimes, as well as always kind of pulling in support if possible, right? Is there anyone in your life that you can turn to for support, discuss how you're feeling outside of just the clinical space? So the other thing to keep in mind is that it's critical to keep this trauma-informed approach to avoid triggering symptoms of visits, right? Best case scenario is we know there's a history of trauma or PTSD symptoms and we can do something about it. And And so by assessing trauma, you can realize kind of this widespread impact, recognize the signs, and then now we kind of respond to how do we integrate trauma into policies and actively work to resist re-traumatization. And re-traumatization is a situation, attitude, interaction, or environment that replicates the events or the dynamics of the original trauma and essentially kind of triggers a trauma response. And that can come with overwhelming feelings and reactions associated with them. And so the idea of like re-traumatization is, it can be obvious, right? You know, someone has history of abuse, you see someone put a hand on their shoulder and they jump. It can also be not so obvious, right? The smell of cologne or perfume might be similar to the abuser. And the whole idea is when we know there's a trauma history, we can do different things to try to make them feel more comfortable in our space and avoid this re-traumatization. So, you know, this idea of this trauma-informed care and working on this piece of the AAs is really going to simplify to these three main principles, right? Patient-centered communication, understanding health effects of trauma, and then also interpersonal collaboration. Right? And see, here are some examples when someone has disclosed they experienced trauma, right? How can you sit with patients, provide eye contact, right? Prior to physical examination, you know, say this is what's going to be involved, let them ask questions, again, really kind of building up autonomy, right? As well as, I think this is very similar to what we've been hearing in the morning, is like understanding that some of these maladaptive coping or health behaviors can actually be related to a trauma history. And how do we talk with our patients in this collaborative, non-judgmental fashion when we talk about health behavior? Lastly, right, so the last component is to arrange referrals, follow-up visits, resources, and continue to follow up. This is multidisciplinary, right? This does not all fall on everyone. It's really about how can we kind of make this space where we work, include others to help make this happen. Nurses, front desk staff, social workers, to arrange more services, to help you know, kind of make sure that they're continuing to follow up and essentially be there to advocate for appropriate resources, knowing that they may require some more. And then just something to keep in mind, something I like to remember, is that perinatal patient may have more interaction with the healthcare system and especially during their pregnancy, than at any other point in their life. And this could be the first time they're disclosing trauma, and this also, or even if it's not, could really be a meaningful time for them to try to get some help for this, if this is something that they're interested in. So, and lastly, again, here are some concrete steps that can help patients, including providing psychoeducation, right, on how trauma can present in the perinatal period so they don't feel alone or like they're crazy, like there's something wrong with them. Asking patients to disclose the history so they can create a plan during pregnancy and postpartum period. Writing out a birth plan to again for more autonomy and control, as well as to check out some other self-guided resources. There's a lot of literature out there, and to kind of point them to some places that might be helpful. Also, I like to bring up the idea of treatment. Not everyone who's experienced trauma or is experiencing PTSD symptoms wants treatment or is ready for treatment, and to discuss it as something that is an option, but doesn't have to be the only option. There are other things that can be done and care is available. As well as this, really want to stress this checking. Always the same way, but essentially checking in on their emotional health. It's not a one-time screening. The idea isn't done just one time, it's really about kind of continuing it over time. And again, action steps specifically for traumatic birth experiences. So previous was just for kind of trauma in general, but we think about traumatic birth experiences. Really talking about, again, going back to normalizing, letting them know that it's common, asking them to reminding them that they're not to blame for having responses, and to become PTSD. This is something that maybe treatment would be beneficial. Talking about it, normalizing it, and letting it be something. We also have, I like to include it as there are resources. So say someone is experiencing trauma, PTSD, would like some resources, and this I believe is included in the slides that'll be passed out. Is we have resources at IU School of Medicine. We also keep a resource database of everywhere in the state that offers trauma-informed care. Psychiatric for psychology and some psychiatrists also have to pass it along if it's not feasible to do to be a part of clinical research or the research lab or the clinic. I just want to end with, this is the project that Dr. Johnson and I are working on. We're really working to include screening for trauma exposure and experiences of racism and discrimination in perinatal spaces, so we can work to eliminate this very these spaces and really want to help our patients and train our trainees to have this worldview and this way of patients that way. That's all for us.
This session, we anticipate a lot of OBs, are kind of getting this message. But I'm just, as you're talking, I was thinking about a client who I had who ended up in the emergency room and had a history of sexual trauma and was actually re-traumatized in the emergency room during the course of a miscarriage. And so, in terms of the medical community, is the message getting to the ERs about how to respond and how to treat women and screen?
Okay, perfect. So I think that the quick answer is not yet, but that is the goal of our project. So our project is actually sponsored by the School of Medicine, and the goal is that these educational tools that get developed through this grant then get implemented in the medical school. So not just people who are going into OBGYN or psychiatry, it would hit future emergency medicine physicians as well. So I think that probably before I retire, it will be something that everybody's learning about and thinking about. But our goal is that we start with our groups and then hopefully disseminate it further.
Hello, my name is Diana Safo. So I'm a resident here doing family medicine and obstetrics. And so one of the things that you mentioned earlier in the presentation from a patient was about the time constraints. And I find that even in residency it's difficult to give an appropriate amount of time to address a lot of these things during the visits. So I was curious how you handled that in a succinct way, and if you had any suggestions to pass along for other providers that are restrained by time and how we can still provide adequate care.
I think that you bring up a very important point in that there are so many things we have to get through during the prenatal visit. I think I have not mastered it yet. I am frequently behind in clinic, but I always start my visits by saying, I have lots of things to talk to you about today, but I want to make sure that we touch on the things that you want to talk about. So is there anything that you want to make sure that we answer before we leave today, or something that's been weighing on you? So I would say that is a great way to at least address kind of the most important things to your patient. And then of course, with the caveat that, hey, if we can't get to it all today, because I also know in training, it's hard for you to maintain continuity. And so I think prioritizing kind of what the goals of the visit are is really important when you're constrained for time. And then I think what has been really great about us starting to pilot the screening is that it isn't really taking that much more time. And so we haven't really gotten into kind of the post-screening counseling yet, but what we do know is administering like the everyday discrimination scale and the PTSD screener isn't adding like 20 minutes onto the visit. And so I think that we also need to kind of reframe what we think is going to be a task that takes a long time.
My name is Tamara Christovan, and I run a support group, a breastfeeding support group at St. Joe Hospital. And birth stories come up a lot in a breastfeeding support group. And I was just wondering, in that group setting, like many women need to process and they don't feel like there's many safe places where they get to talk about their birth story. And there's a lot of fear and anxiety that they did something wrong. And in that community setting, what would you recommend? Breastfeeding counselor, we do a lot of other things in those support groups. So what would you recommend for trauma-centered care in that environment.
I think two things I'm thinking about with, the first is because it's a group setting, I think we talk about wanting to not be re-triggering. So I think often in group settings, we might say, kind of, if you need to take some time, right, if this is re-triggering, if you're just discussing the details, like you need to take some space, that's okay. Or to be like, can you kind of a little bit of an overview? So I think I would encourage it to talk about it and to almost like be like, maybe try to set some parameters around it. So like, if this is something you're dealing with, we would like to hear maybe not too much, not as much detail in this space if it's not able to be continued, because I think the word would be kind of opening it up and not being able to close it in a safe way. But I almost wonder if just kind of more of a cohesion, like, is this something you've experienced and maybe trying to but acknowledging it and letting it know that it's a space to be, this is something that is believed in resources and can be powerful, as well as I think it's really powerful in the setting to have other individuals be like, not even like, oh, I can relate with that. So I think that actually could be really powerful. Do so in a way where folks.
I think we have time for one more question.
I think it's interesting, but I'm gonna follow up that question because mine's kind of an extension off of that. But the idea of breastfeeding in general is, or chest feeding, it's considered re-traumatization to someone and being touched in that kind of way where they don't necessarily feel like they have choice. And the idea that a lot of hospitals are moving towards baby friendly, which certainly promotes the idea of breastfeeding. It can be very shaming for some women. I just want you to kind of speak to that a little bit and how we can kind of keep that an open mind and have a conversation about the different ideas of feeding while still considering their trauma history.
I think the two things to like the kind of in just very simply to be asking is this again all about giving this idea of autonomy and choice back, right? Is this something you're interested in doing rather than like I'm thinking going to prenatal care myself where it's like, are you breastfeeding? It's not even are you breast or bottle feeding, just are you breastfeeding, yes or no? So I think acknowledging like, hey, is this something, asking is this something you're considering, as well as letting them know they have a choice, asking consent before touching or asking consent to assist in any way. I think that idea of you are in control of your body and it is with your permission I touch your body or I ask you these, I talk with you about what you want to do with your body is something that would be a simple intervention to start that conversation. Thank you so much. Hello, we're gonna get started. Thank you so much everyone for being here. Love seeing your faces, love the interaction, and thank you to all of our panelists and everyone who has spoken so far. My name is Kelly Breeden Inham and Mahogany Maternity, and this session is trauma-informed care from principles to action. Trauma-informed care acknowledges the need to understand the patient's life experiences in order to deliver effective care and has the potential to improve patient engagement, treatment, and adherence, health outcomes, provider and staff wellness. We want to focus on the next 50 minutes talking about trauma and trauma-informed care in your settings. We invite you to think about how we build connection and trust, how we create health settings where women feel safe, where culture and history are respected, how we humanize, empathize, and validate healthcare settings that encourage quick interactions. Participants today are from different settings, working with different populations with different types of trauma. We may have our own trauma history, as we learned most of us do, right? This session is going to be in smaller groups, but we hope you can talk openly with each other. In your packet, in your folders, there are different questions for each group to talk about. You will have 20 minutes to talk about one of the questions with your small group, and we will come back together to share. When you're with your group, decide who will be the note taker and report out to the larger group. There is a color sticker on your folder.
Find one or more people that match your color sticker and discuss your assigned question. Okay, it's on your, oh, forgive me, it's on your paper. Open your folder, my paper really inside. And we will see you in 20 minutes. For our groups, we could sew and each group speaker prepared. We're gonna have 5 minutes per color to respond to questions. Each color will have 5 minutes to respond.
That's awesome. Oh, thank you.
So we're gonna start our 5 minutes, and can we have our first question answered by our red group? Red, you have 5 minutes to answer. Hello, Red.
So our question was, what does trauma look like in your life and or in your setting? Have your patients, clients, providers talked about trauma differently than how you understand it? It was beautiful group of people. The thing I noticed is that, right, we have self-selected to come here today, right? We're not the typical, like you just randomly selected a bunch of healthcare providers and what their experiences and their responses. And so we shared about our own personal experiences with trauma, and just that, like, this is a safe space that we could do that. That's really amazing. And it does inform our care. It really, because we obviously are here to learn more about this, we see the need, we walk in that door. And so trauma-informed care is something that we were all practicing. Didn't matter what our background was or if it was quote unquote our job, because it's about taking care of patients. And so we were all doing that in different ways, or at least trying to, and feeling like that there really needed to be a lot more. And then how birth trauma being such a big topic, and how there's not a lot of spaces to talk about birth trauma, and some experiences with that birth after the birth trauma, and how, you know, maybe your doctor was perceiving like, why are you so anxious about this right now? This baby's fine. Yeah, but the last baby wasn't, right? So really interesting, like instead of that whole idea of what is wrong with this patient, right? What has happened to this patient? I loved that. I'm really gonna keep that in my heart. And then we were just talking about changing our approach with individuals, right? Trying to really, how can we walk in that room with compassion and understanding instead of judgment? And like, I don't see why she thinks this is such a big deal, right? Thank you.
Thank you so much, Red. We have our blue group come up and speak, please.
Oh, okay. So our question was, what tools do you use to gather patient information surrounding trauma? And how do you utilize that information to improve outcomes? Our group, none of us were necessary, or we had maybe a couple who were people who would be using tools in the community, but most of us were doing other things in the community. And so we didn't really have necessarily specific tools that we used, but a lot of us were talking about meeting people where they were, helping to empower them, and sorry, looking through my notes real quick. And then just providing that safe space for them to feel comfortable talking about their trauma, we felt was really kind of the most important thing, that unconditional positive regard that keeps kind of circling around here, we felt was really important. And then reminding the mothers that their They are the authority on their pregnancy and on their child and caring for their child, helping them feel seen and heard and validating their experiences. And then using all of that to just further empower them with knowledge and their ability to advocate for themselves and for their pregnancies.
Thank you.
I'm gonna actually insert to. So it's gonna talk about the question.
During our group, we talked about a specific tool we use at our organization, Healthy Families. It's called the Frog Assessment Tool. We use this when we first meet the families. And it addresses 14 different categories from childhood experiences, both negative and positive, previous experiences with children. We talk about how they're feeling prenatally, if they're prenatal, or how they're feeling about the baby postnatally. We ask them to describe the baby in a few words. We talk about their environment, how they grew up, how they do discipline, how discipline was one of them as children. So some of those stories tend to come out with trauma that they experienced. We then use the tool to match them up with a person, and it helps guide services, and we use the tool throughout the services that they receive. We get families from prenatal, and we serve them all the way until the baby turns 5. So we're able to still use this tool to address traumas that they've dealt with, as well as, like you said, meet them where they are and help them advocate with doctors. One thing that I said that I had noticed was a lot of our families tend to shy away from asking, questioning authority and asking doctors questions. So we encourage them to write the questions out ahead of time before they go to the doctor, so that they are not forgetting anything that they want to know or stumbling over their words or getting nervous. Sometimes we do better when we read from something. So that's something that we use. We also use the IPV tool, which they use at the hospital as well, to address if there was any recent trauma that we should be looking out for and assisting them with referrals to the community.
Excellent, thank you. We have another blue, or are we good to move on to green? Okay.
Much been said, but I'll say a couple more things.
We had a really nice collegial discussion back there because we're all from slightly different places and populations. So there were a few of us who used the ACEs, but then there were several other screenings that we used. One was a lifetime history, trauma history, that was very broad and deep. But then also we talked about history taking in and of itself and how that can be done in a trauma-informed way, to invite just sharing about ethnicity and family culture and that family history, those sort of things that might inform us about the patient or about signs that there may be a trauma history there. So a mixture of items. A lot of what we talked about in terms of improving outcomes had to do with using the tools to target the right referrals and recommendations and resources and education for them. And also we talked about using these same tools or different tools later on, especially towards the end of the span of our care, just to reassess where that patient was and if there are some referrals that might not have been needed prior, but maybe needed towards the end of our services. We could pass that on or get that started before we stop services.
Thank you. We have a representative from the green group. Thank you.
I can't remember the last time I talked into a mic, so hopefully you all can hear me. So our first question was, how informed are you all about trauma-informed care? And I think everyone's answer was, we are informed about trauma-informed care, although we were coming from really different backgrounds. A lot of folks were in the medical field in various kind of roles within caring for maternal mental health. I have a psychology background, so it looked a little bit different for each of us. But in terms of how we apply that to patient care, a lot of us were saying, you know, we don't walk into the room and meet someone and say, I'm going to be treating you from a trauma-informed lens, just because we were like, we've not been informed that would be a pretty helpful approach. But rather, it was more so the way that we try to approach our patients. So saying things like, you know, paying attention to the patient's physical cues. So if you're noticing that they're avoiding eye contact or starting to freeze up, that's probably a cue that maybe you need to slow down or provide that person a break. Asking permission for doing things like touching them or touching their children. Explaining why you may be doing certain tasks or asking certain questions so that these people feel empowered to make decisions about what they want to consent to allow you to do. Honoring people's requests for you to potentially stop doing what you're doing, allowing them to take breaks, empowering the patient by providing information about their options and truly giving them options whenever possible. You know, sometimes folks were talking about like, I work in the ER, and so I'm in a very quick rush to potentially save this person's life. But if somebody on your team can take a minute to explain to this person why you're doing what you're doing, I think that can allow people to make decisions that don't feel re-traumatizing and like their power is being stripped from them in that moment. One of our teammates also had a really great point about educating our colleagues about how their work with their own patients could be more trauma-informed, because like someone I think on the red team was saying, like, this might be a pretty special group of people and not all of our colleagues have the same approach that we do. And so feeling empowered ourselves to say to maybe like somebody who's been in the field for a really long time and doesn't have the same lens, like, hey, maybe try asking the question in this way, or maybe they would respond differently if you approach them in this way. And just providing validation and answering patients' questions in a way that's compassionate.
Thank you. Do we have another green or are we moving on to pink? Pink is.
Okay, so our group, we talked about how our work setting is trauma-informed care, or how we are trauma-informed in our work setting. And so we talked a lot about, and I'll just kind of break down, we had kind of 4 main areas. So we had Milk Guide, Oak Lawn, Healthy Families, Community Partners, and then we also had a lovely student intern who was in our group who kind of talked about their experience things and learning this side of it. So in general, again, with this population, I think trauma-informed care is a part of our work. It's part of everything we all understand. So I think we really just explored how we're doing that, and then we wanted to talk about ways we could improve. And I think we all are going to be walking away with things we want to do differently and include. So we talked about more screening tools, including those as well, and having the trauma-informed screening tools. We talked about our physical spaces and how we can make those trauma-informed. So like at Oak Lawn, when the mom or client is coming, what does the physical space look like? How are they being greeted? How are they being welcomed? And as well as the staff, how do the staff feel? Do they feel that the space is trauma-informed? Is there areas where doors could be hitting them or they could be exposed to things? And so having those conversations and including self-care. So that was a conversation we talked about, is increasing self-care for the providers. And that was something I was thinking about for us at our organization. We do offer EAP. So for our staff or anybody, they have 4 free counseling sessions. So we try to be trauma informed with our staff as well. Then with our clients, of course, Michelle mentioned we do lots of screening tools and stuff. We use EPS, we use the CESD, the FROG. We do counseling referrals. That was kind of common across the board as well. So we have those conversations within our sessions and with our clients, but we're always welcome to be referring out and providing additional services as needed. This was really important. I like Jason said, just being more intentional about
understanding their story, really being present with that, hearing them. And I really like that we can always do better about making that space to just hear people's stories. I think that's that unconditional positive regard theme throughout everything we've been talking about. So I think that was everything. I will put a little PSA out there. There's a book coming out, Heal Your Heart, Heal Your Trauma. So do we have a release date? Heal Your Heart, Heal Your Child. Do we have a projected release date? Summer, okay. So potential really great book to be looking out for, and how we can have conversations with moms about healing their trauma, how that impacts their child, and healing their trauma helps create that safe space for their child. So I think that covers everything. Oh, I do want to mention ATIP. We also talked about getting ATIP trained. If anybody does not know what that is, it is a brief version of EMDR, which is a specific form of trauma therapy. And anybody can be ATIP trained. A lot of times they will use it for like first responders and stuff. And so that was a really great suggestion that was talked about, was getting ATIP trained. So if we are having those conversations with the mom and saying, how was that experience for you? And we're seeing some of that trauma, we're seeing traumatic responses coming out, doing an ATIP intervention. So anybody has questions on that, Google ATIP or EMDR, but I think there was a booth out there that was talking about some of that EMDR training as well. So, okay, that covers it.
Thank you.
We were the other pink group, and the second part of our question was in what ways we can do better, which was a really good segue because I work in the forensic department at St. Joe, and I was just talking to my colleagues about this. The question that one of my colleagues wanted to ask the previous presenter was about how in medical situations, like sometimes there's no way around these events that we have to do medically that can be re-traumatizing. Like she was talking about in the ER and the miscarriage, like if they need to medically look down there, like that's going to be traumatic, but medically that needs to be done. And so coming from a sexual assault nurse examiner standpoint, the same thing, like they've just been through such a traumatic event and we have to do these things, you know. So we were just kind of talking about the ways in which we can be better about that. And there were some suggestions in terms of like meeting with other groups in the state to kind of do like case review and this is what's working, this isn't working, which we do a lot of already. We have representatives for that. But then also one of the girls in our group is like a care coordinator. Is that right? Care coordinator through Beacon in their residence group. And they're so lucky in that she's able to take time with these patients to have, like she said, over an hour conversation with them about the events. And we all know like time is always a constraint in the medical field. So that's a huge service that these patients are able to get. But we kind of talked about like that gap in terms of patients who don't get early treatment. Are they being missed? Because that's usually a big population of our patients who need this talk. And so they're working on ways to gap that. And she said they're working on ways to do like where they can have a mobile way to get to them, because as we know, like transportation is a problem, childcare is a problem. So just making sure we're not missing those populations and having those conversations with them that need to be had.
Thank you. Can we have a purple representative, please?
We have two representatives. Hi, so our question was, what is implicit bias? And then what has helped you become more aware of your own implicit bias? We talked a lot about how implicit biases are those things that are generally pretty unconscious, which makes it difficult to identify sometimes. Things not that we're born with, but that we grew up with that really influence how we see people, whether it's of different races or different body types, different sexes, all sorts of implicit biases that we have. And
So we talked about learning more about our own implicit biases, using there are several implicit bias tests that you can do through Harvard, through some other organizations as well. We talked about finding out about our implicit biases from research articles, social media, things like that that I come across, and jive, with us more than anything else. And then we talked about one really important, I think, way of discovering those is interaction, or in our interactions with each other and with people. And when you get that just kind of uncomfortable feeling in your gut, and having those awkward conversations and really leaning into that and figuring out why it is that you feel uncomfortable, why it is that you feel awkward in this situation, and what implicit biases you have that might be causing you to be defensive or cause you to react in a certain way. So yeah, I think that was a
Well, thank you both. Do we have another purple group? We are successful. We have done this. Thank you all so much. You have given some incredible feedback. And I believe that's gonna really work towards some really good outcomes in our community, because we're taking this back to where we work, where we live. I'm gonna start, so I'm gonna keep the conversation going, right? Yes, that one is so nice. So there's a call to action, because that's just the right thing to do. We ask you to answer the questions. These questions using either the QR code that you have or handwrite it on the large sheets in the ballroom. It'd be great for all of us to see your responses. And the questions are, what are 2 things that you will take from this morning and incorporate into your work and into your life? What are 2 changes that you would like to see with how the community or your organization engages with people who have experienced trauma? So what do you want to see change? What outcomes do you want to see? And who can you share this information with in the community at large? So thank you so much. And we are going to release you now. This is the completion of this portion. Again, thank you so much. And don't forget your QR codes, answer the questions, and